Okay, thank you very much, Professor McShane. Thank you for inviting me and enabling us to introduce this paper. And maybe I will introduce Professor Wiesław Cubała and Dr. Mariusz Wiglusz, who are with me here today. And they are also co-authors of this paper. And as far as my experience, I am a psychiatrist working in general psychiatric ward for almost 15 years now. And my scientific interests are mostly treatment-resistant depression and also treatment-resistant depression and bipolar disorder. I've written some papers on ketamine, but also on clozapine, which is also the field of my interest. Well, I don't know, do you think I could start presenting the paper now?
Yes, please do.
Okay. So this is the paper published just last week, and it concerns antianhedonic effect of ketamine infusions in patients with treatment-resistant depression. And before I start talking about it, I would like to thank all my co-authors for work that they put into this project. Anhedonia is a major issue. It is one of the core symptoms of depression, and according to DSM-5, and it also is highly prevalent because it is diagnosed in about 40% of patients with MDD. And it is also significant because according to studies, it correlates with completed suicide, and there is still no approved treatment for anhedonia. And two big studies on antidepressant treatment have shown that it predicts a poor outcome in MDD. And in the base of anhedonia, there is probably dopaminergic and glutamatergic signaling disruption in the reward system. And why ketamine can be useful in anhedonia? Well, according to rodent studies, it increases dopamine release in nucleus accumbens and also striatum and prefrontal cortex. It also acts as an D2 receptor agonist. And through the NMDA antagonism and disinhibition of GABAergic neurons, it increases glutamate transmission. So both dopamine and glutamate are a target for ketamine here. And what do we know from studies which have been published so far on ketamine use as an anti-anhedonic agent in humans? First study was published by Lally and co-workers in 2014. And it was conducted on bipolar patients, and they investigated, the authors investigated the antianhedonic effect of a single infusion of ketamine, and they found there was a rapid and significant antianhedonic effect after this treatment. And the next paper was published by the same group a year later. And it was conducted on a group of treatment-resistant depression patients with MDD. And it also investigated a single ketamine infusion, and similarly, it was confirmed that ketamine had an anti-anhedonic effect in this study. And more recently, a group of Professor Roger McIntyre's published a paper last year, and it was a retrospective analysis of over 200 patients with treatment-resistant depression. Some of them were bipolar, some of them were unipolar, and This study also revealed a significant reduction in SHAPS score as a result of 4 consecutive infusions of ketamine. So during this treatment and after, the anti-anhedonic effect was observed. And now going to our study, this is a part of a naturalistic registry for ketamine in treatment-resistant mood disorders. And in this sub-study, we included 41 patients. 13 of them were bipolar. We administered 8 infusions over 4 weeks as an add-on treatment to standard of care. And we had 5 measuring points. The first one was before infusions, and then at the 3rd, 5th, and 7th infusion. And the last one was 1 week after ketamine treatment. Our primary outcome was change in the Snaith-Hamilton pleasure scale. And we also investigated potential confounders and found a significant effect of benzodiazepines on an anti-anhedonic effect of ketamine. And here we have the SHAPS score change during subsequent infusions, and you can see that there was a significant decrease, and the lowest scores were observed at 7th infusion, and then 1 week after they were a little bit higher. And also here we present the difference between anti-anhedonic, like the power of anti-anhedonic effect in this subgroup of patients who did not take any benzodiazepines during treatment, and below you have the subgroup of patients who did take benzodiazepines. And as you can see, the second group did not really achieve any significant decrease in SHAPS score. And just to conclude, the results of this study suggest that ketamine may exhibit an anti-anhedonic effect in treatment-resistant depression. Benzodiazepines probably attenuate this effect, and we've observed a favorable safety and tolerability profile, but definitely caution is needed since these results are preliminary, and the design was observational. So there is a need for RCTs with longer follow-up in order to confirm our observations. And definitely anhedonia is a provocative research concept, and we have some plans on comparing the results from patients' reported scale, which is SHAPS, with anhedonia described by some of the items from MADRS scale in the future. Okay, and this is our team. This picture was very recent. It was taken today, just so that we can show you at least part of our team. Thank you very much.
Okay, Alina, thank you very much indeed for that. It's really nice to have such a clear presentation of results and just, you know, really nice clear message. And I think what it shows is the potential power of observational data, although notwithstanding your caveat about randomized controlled trials. So this paper is open for discussion now. And our first question is from Tiago Gill, who says, can you just say what you meant by benzodiazepine use, about the doses and frequencies? How did you define that? And can you say a bit more about the benzodiazepine use that you observed?
We did not go into detail as far as the kind of benzodiazepine that was used, but most commonly we used lorazepam and sometimes diazepam, but we did not analyze the doses in detail here.
Mm-hmm. So can you say a bit more about what typical doses of and can you say what proportion of patients were on benzodiazepines?
I don't remember exactly the proportion now, but I will check it in a moment. But as far as doses, we normally use like 1 milligram of lorazepam or 2 milligrams of diazepam. These are the standard doses.
And when you say that, are these given at the time of the infusions, or are these doses that the patients were taking before they came to have the infusions?
It was rather between the infusions and not because of ketamine. That was not really a situation where they would need additional medication during the infusions.
Okay, so your typical range of diazepam would be about sort of 2 milligrams. I expect there was a wide range, but
yeah.
You know,
Mm-hmm.
it's not as if most patients are taking 10 milligrams. Would that be correct?
Mm-hmm. Mm-hmm. Yeah, definitely 2 to up to 5 milligrams.
Yeah.
Mm-hmm.
Okay, so they're fairly small. And just on the benzodiazepine thing, we've had a question here from Gerard Marek. Is there a different? So this is asking a key question, I guess, about the difference between the anhedonia and the depression. So the question is there a differential effect of benzodiazepine use on the depression score that matches the differential effect on improving anhedonia? So can you say anything about benzodiazepine effect on depression versus this effect that you've observed on anhedonia?
We did not do this analysis, but I think it would be interesting to look at it. Because we use this IDS-30 SR inventory, so we could compare it and check it. Yeah, it's a very good idea to do it. Mm-hmm.
Yeah.
If I may just briefly comment, we did some preliminary analysis, and it seems to be the observation, but that's like a very rough initial analysis that overall, when you think about the benzodiazepine pattern use that we had in the study, so it wasn't like as the incidental use or any kind of just the rescue medication. So these are the patients who are using benzodiazepines in course of the major depressive episodes at the moment of treatment. And overall, as it does not differentiate to the global efficacy of the treatment, it seems to be impacting simply the anhedonia domain as something that attenuates the effect. So it's interesting, but it seems to be something that really does the difference simply for the domain.
Okay, thank you. And then Kern and Carla have asked questions about the SHAP score. So Kern says the normal hedonic tone on the SHAP score is a score of 2 or less. So this means that you get an improvement with repetitive ketamine administration, but the endpoint scores seem to be around 5, so they're still in the pathological range. So this is, I guess, about response rather than remission. Can you say anything about that?
Mm-hmm. Yes, well, at the inclusion, like 97% of patients had clinically significant anhedonia. But yeah, we just noticed a significant decrease, but we cannot say that it was a complete remission of anhedonia. Mm-hmm.
And just briefly, just to add on to Carla's question, it's not a typical TRD population we are talking about here. So we wouldn't go per the regulatory definition of 2 to 5 inadequate responses in MDD. It is rather the population that fits refractory chronic course, quite far more complex than what we would simply follow the SMPC for esketamine nasal spray. So overall, these patients exhibit much higher burden of the disease.
Yeah, because the episode duration was about 6-7 months, and the number of depressive episodes the mean was 6 in this group. So it was a really treatment-resistant group.
Okay, interesting. Thank you. And were they all outpatients?
No, they were inpatients.
They're all inpatients. Okay.
Yeah.
Thank you. Yeah.
Maybe coming back to this question about the number of patients that were using benzodiazepines.
Please do.
It was 12 patients in MDD group and 8 patients in bipolar group.
So 20 of the 42 were taking benzodiazepines. About half of them. Yeah. Okay. Okay.
Exactly.
So Carla's question was that the mean SHAPS score of 10 at baseline, and this relates to Scott Smith's question. So the SHAPS scale is a scale for tracking hedonia. So the mean SHAPS score of 10 at baseline is not particularly high. Have you done a subgroup analysis looking at subjects with the higher SHAPS score or people enriched for anhedonia?
No, we did not.
But that's excellent idea.
So that's sort of dichotomizing the population as opposed to taking the overall group. Yeah. Okay. Good. And Scott also says, I'm currently treating 500 patients with sublingual ketamine. Wow, that's a busy day. We're following their response on a monthly basis with the PHQ-9 Beck Anxiety Scale, Columbia Suicide Scale, and the PCL-5 for PTSD symptoms. So, and then there's a question there. So I think the SHAPS, is it an quite easy scale to administer? It's a self-administered scale, is that right?
Yeah, it is quite easy to use. It has just 14 items and 4 answers to every question.
Okay.
So it's quite easy. Patients did not have any problems with it.
If we may just share some of the concepts, it's really important to think about the diversity of patients, and SHAPS seems to well fit Caucasian population, overall, let's say, New England population in the area of Boston. So, you need to be aware, thinking about the diversity in the patient in the study. Some of the items may be, they may need readjustment for cultural background. So that's quite just important point. Another thing with SHAPS is that it's a patient-reported outcome, and afterwards, the NIMH team developed a rater-based manual in English. So you've got SHAPS-C, and it might be interesting, at least for the subgroup of patient, to see how these scores actually, are in patient perception and in the rater perception. So it's just like in line in the analogy to just global depression rating scores, that sometimes the effect is seen in the patient-reported outcome. It's not very well seen in the rater-based scorings. So if anyone is eager to do this, it's, I think, really thrilling to observe. And overall, SHAPS is friendly, and I think it's worth investigating because with all the limitation, it's informative and contributes in general to the observation. But it's like what Alina said, is it the best measure for anhedonia? We are quite unsure, but it is something that we're at least capable to have some kind of the comparison and to discuss with the other colleagues' data.
And Kern makes a very good and rather similar point. He says that the SHAPS is indeed easy to administer and is considered a gold standard. However, and he confirms what you've just said, the phrasing is a bit strange, and you do not know exactly what you measure. For example, all items are, would you enjoy something? So they're not really differentiating between anticipatory and consummatory anhedonia, or between sensory and social anhedonia. Alina, do you want to say something about that?
Yeah, it is a bit confusing, really, when I was reading papers on anhedonia, and some of them distinguish between the two and look for some biological, neurobiological biological ground for different kinds, then I looked at SHAPS and I could not really decide which one it is, because it actually does not, the questions are like about anticipation, but in the like the original paper on SHAPS, it says that it actually estimates both. So it is a little bit confusing, really. Mm-hmm.
But still, I think it's excellent point for the discussion. And I remember at ISCTM, the discussion on the measures for anhedonia, it seems to be just, thrilling and novel area to perform recent development. And with the unmet needs and just, all the limitation of the current medication, it's extremely thrilling to observe how we are developing the new tools to have a conclusive and interpretable outcome measure for the things that we were not able to measure with, as usual, outcome measures. So, I think it would be just reasonable to have in mind all the limitations and put them in a very elegant way in the discussion limitation of every single report that we are having. But, it's really just thrilling. We've just read and, have the kind of just discussion on Rogers McIntyre paper and the exploratory data set from votioxetine. And although with a number of limitations, just exploring the data set out of MADRS scoring as a MADRS anhedonic subscore, it still is very informative and seems to be very relevant to the clinical observation and afterwards to the research studies by Andrea Fagiolini that actually showed the same effect. But actually what Roger did was, it was data from, I think, like 10 years ago. It was just the paper is quite recent, right? But it's like with anergia domain, right, in major depressive disorders. So a lot of things to be done, worth investigating, and still it's excellent to just having this, discussion, because perhaps it's a good time to define what might be the outcome measure.
Okay, so Srihari Gopal asks a question, which I think is really key here. Did you have any patients whose depression improved, but the anhedonia did not? I imagine there must have been a good correlation between the two. So you've just presented the anhedonia data. You must have it. What was your depression measure? And can you say a little bit about this distinction?
Mm-hmm. IDS 30 SR was our depression measure here in the study. And
can you say that? Can you say that again? Sorry, I didn't hear.
IDS SR 30. The inventory for depressive symptoms, which is also a self-report measure. Okay. And it also decreased significantly. The scores of depression decreased. We analyzed the item 18 of this inventory, which describes suicidality. And we had a significant decrease, but only in at 2 points, at the 5th and the 7th infusion. It was, we wanted to check the correlation between suicidality and anhedonia. So that's the one that we did, but we did not really analyze separately any patients with this situation that their anhedonia. I cannot tell you more about that.
But I think the general rule of thumb might be that if you are on benzodiazepines, and overall you will be more likely to benefit from this intervention, but perhaps it will not very much improve your hedonic tone. So I think it's rather, that the concomitant medication with the benzo seems to account for non-improvement in anhedonia.
Mm-hmm.
Can I ask then whether the patients who were on benzodiazepines had less of an improvement in depression as well, or did they improve in depression? What about that group?
Mm-hmm. We did not analyze it separately. So
okay, so
but the global improvement was seen in both groups, right? So when we look into the raw data and also other analysis that we actually published this year, what seems to account for non-improvement in anhedonia seems to be associated with the exposure to benzodiazepines.
Well, that's a great thing for us to really chew the cud over and have a think about what the mechanism might be there. But before we do, let's just take the further questions about the paper itself. How frequently was the ketamine treatments being provided? And you've told us when the SHAPS was being obtained, but perhaps you can just rehearse that again. Was it before each treatment or once a week, or aligned in some way with the frequency of ketamine treatments? Can you just go over that for those that missed the beginning of your talk?
Okay, so the infusions were administered twice a week over 4 weeks. So there were 8 infusions, and the time points of measurement of SHAPS was before treatment, and then at the 3rd, 5th, and 7th infusion, and 1 week after finishing of treatment.
And the ketamine was, sorry, I missed that this time. Was it twice weekly or once weekly?
Twice
weekly. Okay. And then Kernos says the Madras Anhedonia subscale has indeed been published, but has no face validity at all. For example, reported an apparent sadness are items of that subscale. Okay, yeah. So that's very helpful.
He's right, definitely.
Yeah. Okay. And then Scott makes the point, based on these results, should I advise all of my patients to decrease benzodiazepine use for outpatient ketamine treatment? What do you think about that? Something we've discussed here a bit before, but perhaps what's your...
Well, our results are preliminary, but I think there are some other, like when I watched the recording of Professor Roger McIntyre, who studies ketamine also in anxiety, and he also stated that he advises his patients not to take any benzodiazepines during ketamine treatment. So I generally think it is better for patients not to take benzodiazepines, no matter what situation. But it looks like there is more and more evidence coming suggesting that it might attenuate the effect of ketamine.
Okay, and perhaps when we get to the discussion, we'll move everybody over now, but perhaps Carla can just remind us of the phase 3S ketamine results with respect to benzos, which have fairly recently been published as well. So we'll just bring everybody over. We'll turn off.